Welcome, everyone. I'm Grace Ferrari, Senior Manager of Education and Client Services at Parkinson Canada. Thank you for joining us today for our webinar on depression and Parkinson's disease. I would like to take this opportunity to inform everyone that today's session is being recorded for future viewing and can be accessed by visiting our website at www.parkinson.ca. Before I introduce our speakers, I have a few housekeeping points to review. For technical support at any time during today's webinar, please click the Tech Support button at the lower right hand of your screen next to the Ask a Question button. You will have an opportunity to submit a question at any point during today's session from your computer screen by clicking on the Ask a Question button and typing in your question. Every effort will be made to answer all questions at the end of the presentation, but we do ask that your questions are of a general nature and are not seeking medical advice. And now I'd like to provide a brief introduction of our presenters today. First, Kimberly Singyen is a recipient of the University of British Columbia Nursing Division Golden Jubilee Scholarship and an Applied Science Rising Star in 2016. She is a registered nurse in an acute stroke cohort and medical unit at Royal Columbian Hospital in British Columbia and has a clinical knowledge and experience in caring for patients with neurological conditions, as well as being a caregiver to her father who has Parkinson's disease. Kimberly has a Bachelor of Science in Nursing and completed her Master's of Science in Nursing at the University of British Columbia. Her Pan-Canadian research study on patients with concurrent diagnosis of Parkinson's disease and depression received the 2016 Outstanding Thesis Award and is gaining special recognition in the Parkinson community after being published in the CMAJ Open in August 2016. Our second presenter is Dr. Zara Goodarzi, who is a geriatrician at the University of Calgary. Her research interests focus on mental illness and neurological diseases, specifically Parkinson's disease and dementia. Her recent work has focused on how we can improve the care provided for those experiencing depression or anxiety in Parkinson's disease. This work includes understanding how we can best detect depression in those experiencing PD. Now, I will turn it over to Kimberly and Dr. Goodarzi.
Hi, everyone. Thank you, Grace, for that introduction and inviting me to present this webinar on depression in people with Parkinson's. And I welcome all of you who may be the ones with Parkinson's, caregivers, and also healthcare providers who may be caring for these patients in hospital or community settings. My pleasure to share with you what I've learned throughout the years in my research. And as Grace has mentioned, you will find that my perspective is based on the current evidence as well as my nursing experience and being the caregiver to my father. I'll let Zara introduce herself briefly. Zara?
Grace has already kind of said everything for me, but I'm one of the new geriatricians here in Calgary, and I have a specific interest in patients with neurologic diseases who are experiencing mental illness from the perspective of seniors, and I'm working on trying to get myself working in the movement disorders clinic so we can look at that kind of approach. My research will be focusing more and more on anxiety and Parkinson's as we go forward, because there certainly is a lot of work to be done in understanding that illness.
Great. So what are we going to be discussing? I think it's a good chance here just to give you an overview where this 1 hour will take us. But I've broken it down to 4 different parts. I have a section at the very end for questions and answers. And any clarifications that we have mentioned that you want us to talk more about. But the 3 main parts really is talking about depression as a non-motor symptom and comorbidity to Parkinson's. Comorbidity just means just a coexisting condition that is occurring for people with Parkinson's disease. Parkinson's is complex, it's progressive, and currently there's no cure, but it has motor and non-motor symptoms. So although the diagnosis right now is currently or based on the visible motor symptoms, and that's usually when someone goes to their healthcare provider just because of their tremors or they're starting to have issues with their movements, I believe that there's non-motor features that we really need to look at and I think recognize and treat just because it just affects the quality of life of these people. So the next thing we will talk about will be barriers in recognizing these depressive symptoms. And Zara will take over for a few minutes and she'll talk about the diagnostic scale that is recommended to recognize these depressive symptoms. And finally, this one is what I'm always excited to talk about, the treatments to managing depression and just the little things that you can do in your daily life. So at the end of this webinar, I hope that you're able to take just one or two things that you will take to improve your quality of life. So we'll begin the next slide here. So depression is a non-motor symptom and comorbidity in Parkinson's. How common is it? A lot of questions. These are one of the first few questions I had before, and it was quite surprising. In my study that I recently published, I had about a sample size of about 1,815 patients across Canada with diagnoses of Parkinson's, and I found that about 38% of them have concurrent diagnoses of depression. So for me, that is quite alarming. As a healthcare provider, I think that is something to be looked at. So depending on the research study that you're looking at, it can go up to 40 to 50%. So this prevalent is something to look at. And these symptoms that are occurring, it can come before, during, or after the diagnosis, as I mentioned here on the slide. In my study, I found that about 58% of them were diagnosed with depression within the year of their diagnosis with Parkinson's, and about 48% had a bit of had some depressive symptoms or had the diagnosis of depression. So just these finding with my study across Canada, it can suggest that these symptoms can present before and even before the non-motor symptoms of depression, of Parkinson's, sorry. And next question I usually get is, what causes depression? And it's fair that having Parkinson's is an overwhelming diagnosis for someone who may be the one diagnosed with it, and also the caregivers or the family members. So it could be a stress, a natural reaction to having Parkinson's, but we have to remember that there are changes that's happening. It is a neurological disease. So we know that with dopamine, there is a decrease in that, and that's the dopamine is basically the chemical messenger that is controlling our motor, our movements. So when it comes to depletion in this, there are other chemical messengers that are affected, and particularly serotonin and norepinephrine. So serotonin is really what controls or regulates our mood, and so it's not a surprise that depression is quite common in people with Parkinson's. Just with so this is what I want everyone to understand, that the underlying pathways that's happening in the brain is not just the dopamine that's being affected. There are also other chemical messengers that are affected in this. So how do they present? How do these symptoms present themselves? I have highlighted here the overlapping features. Depression and Parkinson's they could have similar features, and this is where Zara's slides will come in a little bit, where it's not just the temporary feelings. So for example, for someone who has Parkinson's, during their on and off periods, or if they're freezing periods, they could have loss of facial expression. And once their medications kicks in, that facial expression, they go back to their normal self. But with depression, it's the persistent sadness, that the feeling of continuing to feel sadness or loss of interest in the activities that you're usually doing or hobbies. There's a low energy feeling that's also persistent. Feelings of guilt. There's changes and impairment in their sleep. So during the day, you can feel very sleepy. And then at night, your sleep is fragmented. In terms of your weight, it can increase or it can decrease. So these are things that depression symptoms can present themselves. So I'll move on to the next part here, which are the barriers. What could be hindering us from recognizing and treating these symptoms? I will be talking about 3 points here, and I think one of the big things that we need to look at are the barriers in recognizing these. So the stigma in having depression diagnoses. For people that are diagnosed with depression, and the stigma that is attached to it, it can lead to the reluctance of seeking help. And so these symptoms just becomes invisible and undetected. As I said, it's understandable that these people can feel this way, and it can create fear and for being stereotyped. But it's important to know that it's not a sign of weakness. As I said, there are changes in our brain that is occurring that's causing it. So it's not just someone can snap out of it. So next thing is the low baseline knowledge. And this isn't just for people with Parkinson's, but it could also be the caregivers and providers. It's important that we know these symptoms to detect it and distinguish it from if it's Parkinson's symptoms or if it's actually depressive symptoms. And another thing that I find are the limitations in these diagnostic tools. There are a range of scales that providers can use to detect depression, but which one is we believe the best one or the recommended one? I think Zara can speak more to this. Did you have anything to? Do you want to start your slide, Zara?
Sure thing. So, when we're thinking about how we go about detecting depression, given that we know that it's common, as Kimberly's already highlighted, it's imperative that we have clear processes that we use to detect depression. And the first step in this process is to screen patients for depression using a tool or questionnaire. But as Kimberly's already mentioned, these tools, we need to be sure about them. As far as their accuracy, we want to make sure that they're easy to use. And in finding those patients, helping us to figure out who might need more testing down the line. So the use of these tools helps your healthcare practitioner make the diagnosis, especially because mental health resources are limited at the front line. If a person has a lot of depressive symptoms that come up on a tool or questionnaire over a certain cutoff, we would say that that tool is positive or that person is likely but not confirmed to have depression. So the steps following a positive questionnaire are important to recognize. That a person then must seek a healthcare practitioner to complete a formal assessment, and in that diagnostic interview, confirm the diagnosis, assess severity of symptoms, look for suicidality, and determine the urgency of treatment. As part of that diagnosis, it's important that the practitioner looks at other causes of depression, perhaps important investigations, and start to initiate a really collaborative treatment plan, because the treatment, as Kimberly's going to talk about, requires a few different people to be involved. So in order to try and understand which tool is best, we performed what's called a systematic review. That means that we took all of the existing published scientific studies that look at these types of tools and tried to figure out which was the most accurate. We reviewed over 8,000 different studies, which I have to say took a little minute, and identified 21 different studies looking at 24 different depression tools. We compared these different tools, specifically looking at how accurate they were, so whether they could reliably find patients with depressive symptoms and not miss those with significant symptoms, which is the most important thing when we're screening. We don't want to miss people. Otherwise, they're going to continue to suffer. So we did find several different tools, but for the sake of the presentation today, we're going to talk about the one that was felt to be the easiest to use and most accurate, which was the 15-item geriatric depression scale. This tool was originally developed for seniors, but in this particular study, we found that combining the 6 studies that actually looked at this tool, using a cutoff of 5 yes answers out of 15, the tool would have a 91% sensitivity, which means 91% of the time, if a person has the symptoms of depression and is diagnosed as depression later, well, the test will be positive, meaning it's very accurate and it enables your healthcare practitioners not to miss people. This type of tool can empower the individuals as well as their providers to both initiate the conversation about mood, but also facilitate the diagnosis. So just briefly looking at the tool, it might be a bit small on your slides there, but the questions themselves are meant to be answered by the patient. They don't need help to answer the questions, and the questions are focused largely on the symptoms of mood versus focusing on the physical symptoms, as Kimberly's already highlighted. There's a lot of overlap in those symptoms, so they try to focus more and more on just the mood symptoms of depression. And as you can see on the blue side, it sort of shows you yes or no answers as to how you might score the questions. So it's certainly easy to use. Certainly, patients can fill this out even before they've seen their practitioner. And I'm sure, as you're all aware, when you're in the clinic, it's a busy place. So having something that you can do beforehand in the waiting room helps to kind of open up that time, especially given that the tool is accurate. So I will pass that back off to Kimberly.
Thank you, Zara. No, with that scale that you just talked about, and I think that it's quite helpful, especially that you mentioned that it focuses on the mood. So just to clarify, the self-rated is what is being provided to the patients, right? And the one Correct. On the right side, the short form, is basically how you tally up the...
Yep.
How severe, how mild, or your severity of depression. Right. Okay, so I think this part is, we'll talk about the treatments. Now that we've discussed about the symptoms of depression and how we can best detect and diagnose it using the geriatric depression scale, we can move on to depression. I like quotes. I don't know if you guys like quotes, but I've included this in this slide. Michael J. Fox, we know it's a great advocate for Parkinson's research, and he himself has Parkinson's. But acceptance doesn't mean resignation. It means understanding that something is what it is and that there's got to be a way through it. And I think it provides some sense of hope and motivation to what seems like a hopeless situation for people with Parkinson's disease and depression. So to start us off, I've highlighted this section here, Canadian Guidelines on Parkinson's. This is a great resource for healthcare providers specifically, but it's also open for people with Parkinson's and also caregivers. It's posted in the Parkinson Canada website. It's quite lengthy, but there is an executive summary that if you want to just skim through. So this section here is specifically addressing the depression, the management of depression in Parkinson's. I won't go through each one, but since we've been talking about it already, but I want to highlight the last 2 points, that it needs to be tailored to the individual. It needs to be patient-centered because everyone is different. They have different side effects to medication, allergies, and even their age can be a factor in how they tolerate whatever management or treatment that is chosen. The last point here, the amitriptyline, this is a specific medication that is suggested here and included in the guidelines. But I do want to highlight that it needs to be monitored closely. It is an older class of drug. It's called, the class of medication is under tricyclics, but since it is an older drug, there are newer classes. And in terms of this older drugs, there is greater incidence of side effects for people, especially in older adults, where Parkinson tends to be more prevalent. They don't tolerate it that well, so what kind of side effects are these? What am I talking about? These can range from dry mouth, being drowsy, which can increase the risk of falls for people, constipation. So this is something that we could monitor, whether you're a healthcare provider or you're the caregiver, or even you as a patient with Parkinson's. So this kind of medication. To elaborate further, one of the first things that we can do or that are prescribed are antidepressant medications. I talked about earlier the newer classes of drugs. These are the SSRIs, so the selective serotonin reuptake inhibitors. That was a mouthful. So these are the Paxil and Celexa, and also the SNRIs. Example would be the Effexor. So these medications, they target the chemical messengers that I talked about earlier in our discussion, that they target serotonin and norepinephrine, and these have roles in regulating your mood. And finally, the tricyclics, so the amitriptyline. In the study that I've had, it was quite interesting on what is actually being prescribed across Canada, which ones are more common. And I found that about 52% of them are receiving selective serotonin reuptake inhibitors, so the SSRIs. And yet, if you can recall, in the guideline, it's the amitriptyline that is recommended or suggested. And that's just because there's still a gap. There's still a lot to learn on the efficacy of these medications, how they work in people with Parkinson's disease. There are some great studies, large studies, that have looked at and compared the different kinds of medications, and they found that there's some studies that have shown that SSRIs, although they have better tolerability in patients with depression, but when it comes to patients with depression and Parkinson's, it can magnify their motor symptoms. So that's something that you need to watch out for. So, and something that is an area of research for those in that section in the medical field. When it comes to amitriptyline, studies have shown, and I think this is why the guidelines have recommended this type of medication, is because it has shown in evidence is showing that it's more effective. It has more better efficacy in treating depression in patients with Parkinson's. So I thought that is something to look at and know that although we have these medications, not everyone tolerates it the same way. So I've included this just with the primary care practice bullet here, where my study is really based on. It's patients across Canada in primary care settings. And I've taken all these informations from a surveillance system or a surveillance network that provided us this information. So for people with depression in Parkinson's, the severity of it needs to be considered. As I said, it needs to be individualized, but it doesn't mean that you need to be on medication right away. For people who have mild or moderate depression, there are other treatments, other ways to manage depression. And I've listed three points here. One of them is psychotherapy. So this is really a talk approach therapy, and it can range from you setting an appointment with a healthcare provider that will help you talk about how you're feeling, your mood, changes in your life, things that have been effective. And it's easy for me to say reduce stress. Stress is something that everyone, positive or negative, it's all around us. But managing it and knowing choosing your battles, knowing which one to put your energy on, which one that can wait. I always say to my patient to pace themselves, even though during the day, in the morning, they're at their best. Doesn't mean that you need to exhaust yourself until you're not able to do anything and function. So pacing yourself is quite important. That brings me to exercise. With my father, exercise is a constant battle with us. I've attended a webinar, I've attended a brain health fair here in Vancouver, and they had neurologists all around, coming from the States, all around North America, and I kid you not, everyone was saying exercise. Exercise, whether you have depression and Parkinson's or not. Just patients with Parkinson's, exercise is a big thing to them, and I think I want to stress that with you. And it's something that you can do to yourself. Even right after this, you can do a few minutes of exercise. And what kind of exercise are these? Even stretching. Stretching is a good way to wake yourself up. Walking, doing some yoga, deep breathing and meditation. Boxing has been shown, and there's some classes where boxing has helped people with Parkinson's, helps with their stiffness. And also it allows you to have social connection and social ties with people. So being in a group will help you. I've included Neurofit BC here. I've come across this in the last month, but Neurofit BC, it's a website. It's www.neurofitbc.com, and it is run and created by a physiotherapist. And this physiotherapist have dealt with patients with Parkinson's, and she is great enough to put out videos, free videos. So if you subscribe, go into their website, subscribe. She will send you videos. I believe it's every month, and you can follow it at home, and you can do these exercises, and they're specific to people with Parkinson's. And the next thing is nutrition. I specifically didn't say diet here because I want you guys to focus on the nutrition, but there are things that you can help you can take or watch out for when you're on what you're eating. So nutrition, vitamin B, we know, can help boost up your energy, and D supplements, those are great. The neurologist that I've spoke to with my dad, they recommended about 1,000 milligrams in mcg in terms of vitamin D supplements, and I've included monitoring protein intake. So it doesn't mean that you should lessen the amount of protein that you're taking, but just monitor the time that you're eating and when you're taking your medication for motor symptoms. So I believe that once your motor symptoms, a lot of your motor symptoms is controlled, you'll be able to function better. So I always recommend for you to take medications for your motor symptoms on an empty stomach, just because with protein, it really affects the absorption of your medication. Or another thing is maybe take your medication an hour before you eat, and that's kind of the timeline that I've given for my father, and also for my patients when I'm working and I know that they have Cinemed or levodopa and lunch is coming, so I try to keep it at the same time before they eat their lunch. So eating right is quite important here. And are we on our last slide? Yes, we are. Okay, so we've talked about a lot of things. Hopefully I didn't talk too fast, but just some takeaway message to wrap us off and something that you can take with you before we end this webinar. Clinical depression, it's common. It's common in Parkinson's. We know this now. If we go back maybe 10 to 20 years ago, depression is not really being talked about, but there's quite a bit of research now, and we know that depression is common. So discuss your non-motor symptoms with your healthcare providers. And this will really help us detect and diagnose. And it doesn't mean you have to be on medication or start medication. For some, you can just start off with being connected with a group of people, and you can share some tips with each other on how you can handle stress. Also, eating right and exercising. With exercise, that can help with your stiffness as well. Anything in your freezing, lessen your amount of freezing moments. So a combination I put here a combination of pharmacological and non-pharmacological therapy is maybe warranted to really manage your depression and Parkinson's. And my last slide here, I believe you will have access to this PowerPoint, but the things that I've talked about and links that you can access if you would like. I've included the clinical guidelines and also the studies that I've had. I have the support groups. So these are support groups here in BC. I believe there's some between the provinces in Canada, but I've just had one in the west and east side. In Alberta, there is a PD helpline that you can call. So if you have any questions, I think this is something that it's great. If you have a simple question that you don't have access to your provider right away, especially those not in the main cities. And the Neurofit BC, so the exercise series that I was mentioning about earlier. And Parkinson Canada have lots of resources and information if you want to learn more about nutrition and type of medication, type of food that may help you boost your energy and help you manage your depression. So I guess that concludes our PowerPoint slides. Grace, is it okay if I move on to the questions?
Yeah, sure. Thank you, Kimberly and Zara. You've given us some thoughtful insights and practical information and things to look for. We'll now open the forum up for questions. Again, reminder, if you want to ask a question, please type it in through the chat box down at the bottom right. I've got two questions that come in. The first one is, do people living with Parkinson's often need antidepressants?
No, not necessarily. Especially for those who have mild or moderate depression, once they're diagnosed, they don't need to start with, I believe they don't need to start with depression. Some other types of management or treatment could be effective. I feel like recommending exercise and nutrition and being able to connect with people, social ties, may be enough to help you manage your mood and boost it up. So,
Zara, how long does it take to start feeling better after someone starts on an antidepressant regime?
Yeah, it varies by the individual for sure, but most antidepressants take sort of between 4 to 6 weeks before you notice significant changes, and certainly some people can take longer. The other thing to think about is, as Kimberly is pointing out, there's lots of different types of antidepressants, and what you might be started on might seem like the best choice initially, but perhaps a different agent might be more effective for you than the next patient after you. And so sometimes there is a bit of a trial and error phase of trying to work through the antidepressants. And I think that's where it is really important that in between that, you're also working on all these other non-medication type things. So therapy and all the things that Kimberly was talking about.
And Zara, is there a difference? Because we get a lot of calls, and we try to, or patients try to differentiate between apathy and depression. Can you talk a little bit about that?
It's an excellent question. Based on the actual, quote, diagnostic criteria, one would say they are different diagnoses, but they have huge overlap of their symptoms, and it can be very difficult for the patients, let alone their healthcare providers and caregivers, to really separate those symptoms. I haven't seen a study that looks at the commonality of the two together as of yet, but it's certainly an area that needs a lot more research. The treatments for apathy don't differ greatly from depression, but the evidence for those antidepressant medications in apathy I don't think is as robust yet.
And what can caregivers do if they, identify some of the symptoms that you both talked about today?
So, just going back quickly to the apathy, the difference between the apathy and depression. It's great what Zara has mentioned. From my understanding, one of the big difference in apathy is that for someone who has apathy, it's really the lack of interest or motivation, but they're not necessarily sad. They don't have that persistent feeling of being sad. So if you were to ask that person if they are sad, they will say no. And yet caregivers will find that they're not doing anything. So it seems and they come across as though they were sad. So that's one of the difference that I find with apathy. There's a lack of interest or motivation, but they're not necessarily having that persistent sadness. And to answer your question, Grace, what caregivers can do, and I think advocating for their loved ones is quite important. They're often the ones that notice the change in the mood or changes in their everyday activities. So being able to talk to or going with the patient when they talk to the neurologist. So I, for one, when my father has an appointment with a neurologist, I go or my mother go, just to make sure that what they've talked about is also passed on, or I know what's going on with him, because with Parkinson's, there are changes in the brain, and it's possible that at that moment in time, they're only focused on trying not to move while they're sitting and listening to their neurologist while they're assessed. You know, the information that's coming in may not be remembered after they leave that room. Yeah, so I'll quickly look at some of the questions.
I can answer one I saw earlier.
Yeah, sure.
Irene Doyle asked a question of whether the diagnostic tool is accurate for people with young onset Parkinson's. It's a really great question, Irene. The studies that we included in the systematic review are the only ones that have been done, and the patient age groups included are between the ages of 40 and 90. So certainly there's a wide range of people who have been included, but perhaps more effort needs to be looked at to pick up those in the younger population. Certainly there's no indication that tool would not be accurate in younger patients, but it's there. Yeah.
Great. So there's a few questions here. The first one by Jacqueline Landry. What is the ratio of patients that are young onset diagnosed with depression, anxiety, to those later onset PD? So when it comes to the research study that I've done, I looked at the age at diagnosis of depression, and majority of them are the older adults. So these ones on average were about 70. Not to say that it's not as common in people with young onset diagnosis. It could be more, it's possible that it could be more prevalent. It really depends on the type of support that you get. So for my study, it tends to be the older adults that are more at risk, and it's possible just because their symptoms are more, their motor symptoms are more severe, and it can aggravate or magnify their symptoms even more. So they're more at higher risk for depression.
And certainly the elderly are at high risk for depression in and of themselves without Parkinson's, so that I would imagine it kind of magnifies things.
Okay, so Gord Croucher asks, are motor symptoms correlated or possibly caused by motor symptoms?
He means non-motor symptoms.
Oh, non-motor symptoms, yes. I know you touched on this, but do you believe successful motor symptoms would reduce depression? Yes, I think, I believe it does. Once you get a handle on your motor symptoms, as I said earlier, taking your medications on time and regulating that really and controlling your motor symptoms can help you function in a more quote unquote normal way, as normal as possible. So that would be what I would say in that. And you answered the diagnostic tools already. I've included the website URL for the videos in the resources. So the Neurofit BC, you can subscribe on that. It's under a physiotherapist. And this is where even Zara has touched on that it takes a combination or interdisciplinary approach when treating depression and Parkinson's, or even Parkinson's overall. You have your nutritionists or dietitians, you have your physiotherapist, your occupational therapist, and in terms of the difference between physiotherapist is really the movement and the exercise. Occupational therapist is your daily life, your living, being able to dress up. Are you able to do your daily life, cooking, grocery shopping, which is important in people with Parkinson's with issues with their mobility. And
there's a question about mirtazapine.
Yeah, did you want to address anything about mirtazapine?
Thanks for your question, Andre. In reviewing the treatment studies, there was actually a recent Swedish study that showed the most commonly prescribed antidepressant in Parkinson's was the SSRIs that Kimberly was talking about, but it was actually followed by the mirtazapine medication. So certainly it's being used for a lot of patients. I know a lot of movement disorders physicians prefer it because they feel there's less side effects, and it certainly has some beneficial effects in regards to sleep. So certainly it's being used a lot. I think there's probably room to look at more specific objective studies in that drug, but it's definitely being used.
Mallory asks about anxiety and Parkinson's.
Yeah.
Have you had experience with, I find that they overlap. The symptoms of...
Yeah, certainly there's been... Sorry, so you go ahead.
So the anxiety, the symptoms of anxiety, similar to depression, it can overlap with Parkinson's. Anxiety is really that the stress that you get, and it can affect or aggravate your motor symptoms. So I think he's asking if there's more information in treating anxiety and in Parkinson's. I believe there is a set of classes of medication for them.
Yes, actually, some studies, not a lot. It's a poorly studied area. There's a few articles. If you look at my name and BMC Neurology, there's a review of all of the available guidelines for Parkinson's internationally. We do talk about anxiety in that study, and then there's several other papers that will be coming out looking at addressing that issue.
Zara, there's also a question here regarding the depression tool. where it says, Heather asks, I'm curious as to why the tool for assessing depression is a tool used with geriatric patients. I'm 62 and I don't identify myself as a geriatric.
It's an excellent question, and it's sort of all in the name. So that tool was created to look at seniors with depression, and it was just in the case of seniors, there's a lot of overlap of depressive symptoms with the symptoms of aging. And so when they originally created this tool, they were looking at trying to ask questions that weren't looking at physical symptoms. And so as it happens in the studies that have looked at depressive tools, like I said, they've looked at 24 different tools. And as they were looking at them, they just included this tool to see if it was effective in Parkinson's. And it just so happens that that was the effective tool. So I wouldn't say that where I see where you're coming from with the name, and I totally appreciate the way it does come across. It's more just that the questions themselves, the way they were designed for seniors, just applies well in the setting of Parkinson's because we're trying to avoid that overlap of symptoms. So that's sort of where it comes from. It's not to try and identify everybody as geriatric. It's more just that the questions themselves were accurate.
Mm-hmm.
We have a question that came in about deep brain stimulation. Does it have any effect on depression?
With deep brain stimulation, I haven't had a patient that has taken that, but what I found in my research is that those ones are really for patients with severe depression, and they have gone through different routes in managing their depression already. But not to say that even if you have moderate to not so severe depression, you're not a candidate. It really needs to be individualized, and you'll really need to talk to your neurologist or your primary healthcare provider in deciding. There is probably, I would assume, a criteria or cutoff where they would say, yes, you will be eligible for a deep brain stimulation.
And do either of you know if severe apathy, maybe Zara, you would know, is it a common symptom or side effect of any of the dopamine agonists such as Mirapex?
I think the apathy is more a symptom of the Parkinson's itself. I haven't heard it as a complication of Mirapex myself. I don't know if Kimberly has, but I haven't heard that myself.
Not much as well on my end here. That could be something that, for sure, potentially an area of research if that people can look at further. There's a few more questions here briefly that I can address. Rick asked, could you review one more time the timing of meds in relation to protein? Yeah, so protein has an effect in the absorption of medications like your Sinemet or levodopa. So it's always recommended for you to take it on an empty stomach. It's for your medication to be taken on an empty stomach just to help get the absorption better and have that good effect on your motor symptoms. So for my father, I have him take it an hour before he eats breakfast, depending on how often you take your medication, but an hour before breakfast, an hour before lunch, and an hour before dinner and at bedtime. So that's kind of his routine, and it seems to have effect. And there are times where, he gets his good and bad days, and fair enough, but trying to have a consistent time really helps have your body adapt to a routine, and you can function better and better decrease the stress and know what you can control and what you could expect in that day.
I don't know if either of you can speak to it, but Donna asks if any of the antidepressants can help with improving motor skills at all. Example, rigidity or neck or muscle strains, aches or pains.
Certainly some of the antidepressants are felt to have effect on pain. Not all, but certainly some of them do. And as far as I recall, there was some evidence showing that motor symptoms or patients who have depression experience worsening motor symptoms. And so I haven't seen a study that directly says that treating depression will improve motor symptoms, but it kind of follows that it might. Kimberly, have you seen anything?
I
haven't seen anything explicit that way.
No, I think at this point I can't recall at the top of my head at the moment.
No, that's okay. There's a question here, kind of earlier, Jacqueline asked about saying that not having a diagnosis of depression or anxiety at this time, but still seeking to have mental health involved in her care. And I would have to agree with you, Jacqueline. I think it's important to seek outlets for mental health, seek a multidisciplinary approach to the treatment of Parkinson's, because it certainly is proactive. It certainly addresses things going forward, and may even help to prevent further things developing from a mood perspective.
I think I answered most of these questions.
I think you touched upon it, Zara, but a similar question is how common is anxiety in PD compared to depression, and can they be separated? I know that you did mention that they are separated or two different diagnoses, but how common is anxiety in PD compared to depression?
So certainly they can be separated, just like it's difficult to separate apathy and depression. Sometimes it can be difficult for depression and anxiety, but as Kimberly mentioned, the anxiety symptoms are more symptoms of worry, symptoms of panic. Social anxiety is a common one, especially in Parkinson's, because of the visible nature of symptoms. And so, it can be separated from that perspective. They're certainly very comorbid, meaning they occur together very frequently. And I believe the recent estimate of anxiety was that at least the prevalence was at least around 30%, which is similar to some of what Kimberly was saying earlier in her presentation. So very, very similar amounts of prevalence. Some studies certainly feel that anxiety is more common in Parkinson's. Again, as a question that Gord had asked, certainly the motor symptoms can worsen depression and they can worsen anxiety too, depending on the individual. So there's certainly a huge interplay between depression, anxiety, apathy, all of these non-motor symptoms and the motor symptoms of Parkinson's, but they can be separated. And it's important to try and do some separation in your diagnosis because there is some nuance and difference to the therapies, but a lot of what Kimberly was saying of the non-medication types of interventions for depression are felt to be effective for anxiety. However, there hasn't been as many studies demonstrating that.
I think we asked the majority of the questions. There's one last one, Grace. And I think you will be able to help with this as well. Could medical cannabis help depression? It is quite something that is new, in not just in people with Parkinson's, but even in our practice in nursing. We're still learning on our roles and what can be done or how it can help. I'm not sure exactly what the evidence is showing when it comes to depression, but I think we're going to be having more information sessions regarding medical cannabis in the future.
I just want to let everybody know that is participating today that our next webinar in March will be on medical marijuana and its use in treating and managing symptoms of Parkinson's. So I think all the questions are done now. For more information, living with Parkinson's, or to access a recording of today's webinar for future viewing, please visit our website at www.parkinson.ca. And if you have any questions regarding today's session, feel free to contact us by email at info@parkinson.ca or call us toll-free at 1-800-565-3000. And before you log off, please take a few minutes and give us your feedback by completing a short survey. Your input is important to us, and it will help us identify topics of interest for future webinars, as well as help us better meet your needs. Thanks again, and have a wonderful day.